I just was diagnosed on the 19th of June this year, but I was misdiagnosed, and I've got they told me it was a fibroid, and it wasn't, and it's spread into 3 places, which is a peritoneum, my liver, and in the small bowel. And they've put me on 400 milligram imatinib since July, and they've just handed me the pill and said, we'll wait to see you in 3 months, see if it's done anything. Now with having a 1-year-old, finding out that I was misdiagnosed, and a 12-year-old and an 8-year-old and 11-year-old, just to take this pill, and it's metastasized. Every time I ask, should I have been on maybe a higher dose? Will it work more? Can I have an operation? No, we don't. You won't get offered an operation. You just have to be on imatinib and take it from there. So, what is at City Hospital? I've yet to meet Dr. Hennings. City, Nottingham.
I'd ask for a second opinion if I were in your shoes.
And I've been waiting to see Dr. Hennings, to meet him. So I work with Dr. Gossage at the minute. But I don't know, we keep talking about GIST before it's gone into your liver. But what happens if it has gone into your liver? Does the imatinib work?
So clearly it's really, really hard to talk in detail about something where none of us have had the chance to look at you as a patient, and that's a really difficult thing to do. But I think that it's entirely reasonable if you have a set of clear questions, that you ask those clear questions of the doctors and nurses where you're being looked after, and you ask whether there are other people you should also speak to. Not in a way that you're doing because perhaps you're feeling upset, but because that's constructive. It's a positive thing to do to get a range of views on what might happen to you. What do you think, Lee?
I absolutely agree with what Judith said as well. I'm sorry to hear about that. That must be a really difficult and scary time for you. When GIST is diagnosed and it's in a number of places, not just in the individual bowel, then it is usually the case that tablet treatment is at least the first thing to do. It should do. So if it's sensitive in one place, it should be sensitive everywhere. For someone who is young, for someone who is fit, I'm sure the team who are looking after you want to treat this as aggressively as can be done to give you the best chance of the best possible outcome. That has to be balanced. Obviously, surgery is no mean thing to undergo, and for that to be recommended, people want to be sure it's the right thing to do. And often, when it's in a number of places, getting things under control with medication is the best thing first. And as we've talked about, there's a very good chance that it's already having a positive effect. And then to come to that and looking at the role of other treatments to give you the best outcome, which always comes with pros and cons. These tablets come with pros and cons that we talked about today. Other treatments will come with that as well. As Dan says, speak with your care team, put their questions to you, they will be happy to address them. If you do want to seek further opinions, that's something that you're entitled to, and again, your care team will have no problems. Patients under my care ask for second opinions all the time, and I think it's a good idea, particularly with rare cancers.
I think with surgeons who say, oh no, surgery is not feasible, one surgeon's no is another surgeon's challenge. And I've known patients where their own local team has said, oh no, surgery is not an option. And they get a second opinion and they see another surgeon and he says, that looks interesting. And surgery can be successful. I've had 3 lots of surgery. I've had liver surgery, stomach surgery, and I was given 2 years because I was diagnosed in 2001. I had my first tumour removed, which was the size of a rugby football and growing very fast. I could feel it growing from day to day, and it was off the top of the scale. I didn't know what the mutation was. It was thought to be benign, quote. It turned out to be a huge, very aggressive cyst. And the oncologist said, well, 2 years, you know, because I did ask. Well, that's 22 years ago. Things have moved on such a lot. And I think, there are so many options now. It's very different from what it was. Question I'd like to ask is, we've been talking about all these 3 drugs using the standard dose. Now, that's the dose that was part of the original trial. Has there been any research into whether, particularly with sunitinib, whether the dose could be reduced and still have the efficacy of the higher dose with fewer side effects?
Thank you. The answer is, to some extent, yes. The relationship between how somebody may or may not benefit from a drug, the side effects that they get, and the dose that they're taking is not neat and clean. Yeah. So I might take 10 milligrams of a drug, yeah, and have a huge amount going around in my blood, and a huge amount getting to my cancer. And somebody else might take 10 milligrams of the same drug and have half as much ending up in their blood because they happen to break the drug down in a different way. So what is increasingly happening, not yet in GIST, although it would be interesting, there was a bit of it done some years ago, yeah, is taking drug levels, yeah, and then taking also tests of people's genetics, yeah, and relating that to how they might break down drugs. And that will enable us to personalise these treatments, yeah? Because otherwise there's a lot of guesswork, and if you put somebody on a drug at a different dose from the one that was in the trial and the one that's established and the one that NICE have ruled on, and you have a problem, then quite justifiably you have an upset person to work with. So you don't want to do any harm to people. It needs to be robust.
I'd agree with that. What informs what is the normal dose for this only partly accounts for that variation that the Professor Stark refers to. One needs to be careful, my general aim is to get as close to the normal dosing as possible whilst avoiding difficult side effects. There is enough data out there to tell us that we can be free about individualising things. I think one has to be cautious about putting the dose beyond the standard level. But
if the patient is having really bad side effects that's affecting their quality of life seriously, surely it's worth trying to reduce the dose.
Absolutely, and I think that's an important point, is that if for some people where a dose reduction is required to make the drug tolerable, that by no means is puncturing the chance of getting the same level of benefit as someone else, because of that reason that the level in that person might be much higher than the next person.
How expensive is plasma level testing? Because it seems to me that, as you're saying, different people absorb the drugs differently. So the same dose will give different plasma levels in different patients. The cost of the drugs is so high. Would it be economically sensible to do plasma level testing so that if you have a high plasma level with the standard dose, you could reduce the dose, have fewer side effects and just the same efficacy?
I don't think it's an economic question in the main. I think it's a scientific question. It's a question about the quality of the measure that you take on the blood for the drug, and a question. So it's in that sort of getting the science right phase at the moment, and it's also a pragmatic question because, for example, some very young people who get cancers have drug level based things, but currently it might take 3 days for the result of the level to come back. Yeah, okay, adding complexity pragmatically, and that's in a well-established system, taking levels of well-studied old chemotherapy drugs. So it's a scientific and pragmatic question. In the end it'll have to be about economics, you're not wrong, but it isn't yet.
Right, so let's take some questions. Yeah, who's got the mic now?
Can I just follow on from what you've just said there, Judith? I had a very aggressive gist, which was removed. I did the 3 years adjuvant on imatinib. 15 months later, 15 months later, I was back on imatinib for life with approximately 5 tumours. Then maybe 2 years into that, I spoke to my oncologist with the side effects, saying I was 50 going on 80 and, your usual side effect. And he agreed to me trying 400 milligrams every other day to give me a day off, And this worked for approximately five plus years. The tumour last December began to grow. So I've had that removed in February. But like he said, he doesn't know if it's because I was only on half the dose or if it would have happened anyway. So now I'm back on imatinib every day to see if it's back working again. So I was actually pleased that I did get that chance to have the 5 years. Yeah, I did. Yeah. So sometimes it's worth speaking with your oncologist and working things out together.
I think that's a really good example of likely benefit from an individualised approach. It's always a challenge applying, the sort of trial data that Dan and I have presented, which is gathered across hundreds of patients, and saying, well, where does the person in front of me fit into that? And, that can be frustrating and sometimes concerning thing, but the flip side of it can be liberating and say, well, given that there's two sides to that uncertainty, why don't we just be pragmatic and try and work towards what seems to be a solution that fits for that person? There's always a concern about a tension between side effects and effectiveness, which there's an individual balance, but absolutely, and there's an element of if the cost of treatment is every day is just miserable because of side effects, then to me personally, I would question if that's the right thing to do.
Should we try from there?
Can I just say one thing that this issue raises is that the relationship between the patient and the team caring for them is absolutely crucial. And if you feel that you can't really talk sensibly to your team and express how you're feeling, I think you're with the wrong team. I mean, there have been occasions where the patient has been terrified of the oncologist. Well, that's stupid. And I have actually suggested, please change the team you're under. And they've come back to me and said, thank you, because it's made such a difference.
Thank you. I'm on sunitinib. I was very interested.
The microphone's not working. Just a bit closer.
Okay. Is that better? Yes? Okay, sorry. I'm on sunitinib, and I was very interested in what Dan was saying about potentially having a break from the drug and then going back on it again, and that potentially increasing the time until resistance. When you talk about a break, what do you mean by that? What sort of timescale are we talking about, please?
There are different ways in which one can do this. It depends on what the problem is that you're trying to get round, I think. Yeah, what your doctor and you are trying to get around. Yeah, for some problems, to have a break, you're probably going to have to be off the medication for only a few days, and that will work. And for other people, they might have to be off the medication for a few weeks before they'll see the benefit that they're after. And for other people, what they're really asking for is a proper treatment break, where they come off the medication and they intend to go back on it when the cancer then grows further again. Yeah, and that last one is an indefinite treatment break, which we all keep fingers crossed is for ages and ages and ages, and sometimes it is. So depends on what problem you're trying to solve, yeah, but in all of these medications, if you're under an experienced group of doctors and nurses who are doing this all the time, yeah, then they've got endless experience of tweaking these different things in one way or another and trying to personalize it to you. You need that relationship because there needs to be a trust in that, yeah? Because you're asking your doctor and nurse, quite rightly, to go, as a skier would say, off-piste a bit. Yeah, you're asking them to go off the regularly written track and do something a bit original and creative to help you. Yeah, and they will happily do that as long as they feel you and they understand that if that doesn't work out, everybody tried their best and nobody's upset with anybody. Yeah, and if it does work out, so much the better. And if that trust and relationship and discussion is there, there is no problem with going off piste for most of us.
I agree, and that's the position that I hope I can get to with my patients, in the position where you know we can share an understanding, share the problem, establish what's the priorities in the situation, and then work towards that together.
But it's also really focusing on how having specialists dealing with you, how important that is. You must all make sure you're dealing with specialists in GIST, of which they are up and down the country.
I'm on imatinib and my plasma levels have started dropping. Is there any reason why I can't just take another 100 milligrams a day to make it 500 instead of 400?
So, I mean, this links to what Judith was saying about monitoring drug levels. So obviously that's been done in your case. For me, the challenge is not quite knowing how to react to that because there's limited data around this to tell us how to respond to that. There is data that suggests that it's quite common that as treatment goes on, plasma levels can go down. It's not quite clear why that is. That may be why side effects, which are problematic early on, can settle down. If that is the case and that's common, then all the patients who were in the trials that were presented, that probably happened as well. And so certainly we can take it from that if in an individual the plasma levels are falling, that's not going to disqualify you from the same level of benefit as is in the study. Whether or not increasing the dose is going to add to that benefit is not known. That's not been properly tested. There's compelling reason to think it might add to side effects because, as I pointed out in my presentation, many of these side effects do tend to relate to dose somehow. So I'd see that in a situation where it's interesting. It's certainly been seen in other people that plasma levels are falling, but is increasing the dose going to be the right thing to do? I think there's a big question mark of that, and personally I'd be a bit... I probably wouldn't recommend for that. It would be my personal thought.
Where we've looked at getting better benefit in terms of cancer control from changing the dose of most cancer drugs, the amount we've had to increase the dose to get a really meaningful further benefit is much larger than most people are comfortable with. Yeah. So in many cancer treatments, you can probably kill more cancer cells if you give 3 times as much or 5 times as much. Okay. But, as you can see, that's very problematic. Yeah, and nobody's saying that's the right thing to do unless somebody's in such a desperate situation that that's what they wish to do. Yeah, okay. Well, cost? Yeah, well, yeah. It might or might not. That's a whole sort of other area. It's usually possible to do these things. It's better to do them in a research study than it is to do them as a one-off. And there's an interesting study opening at the moment, which is trying to collect the people who are having one-off approaches taken. Yeah? Yeah, do you see what I mean? It's not in this specific context, but that's a process that can go forward, and it's something which actually patients could get involved with, actually, really. Yeah.
What we need is people in Parliament that can really push this for us as well.
Hi, quick question just relating to the imatinib. What would qualify you to be recommended to take it for longer than the 3 years, I guess? And at what stage is that decided?
And so, there is research which is looked at or is looking at the benefit of taking it for longer in the adjuvant setting. Yeah, okay. And so this information will come forward. Yeah, there are people who take it for longer even though they've not got their GIST apparent on their blood tests or their scans, and that's because there's reason to expect it might still be inside them because of how it was diagnosed at the beginning. That particular situation where a surgeon goes in to remove a gist, but actually it's already escaped, and it can't be seen necessarily on the scans, but we know together that it's there. Yeah, so those people might take gist for more than 3 years, so imatinib for gist for more than 3 years, yeah, even though their scans are clear. Given the data on treatment breaks, that's not something I want to do very often. Yeah, but there are those things, and to take it unlicensed for longer, i.e. as an established thing that's been properly reviewed and approved, I don't think we have the data yet. Do you know the data yet, Alex?
No. So as Dan says, there was a trial that was recruiting in this country as well as across Europe, which completed recruitment about a year ago, comparing the now standard 3 years versus continuation to 5 years. It's going to be a good number of years yet before we get the results of that. That will clarify it, but that's years down the line. There is fairly compelling reason to believe that if one is in a position where ultimately you're destined that the gist is going to come back from stopping imatinib, that you're probably not worse off coming off the imatinib and resuming than if you just continued all the way through. There's data that supports that stopping, if there is recurrence, resuming at that point is probably not going to produce a significantly worse outcome than if you were just on imatinib the whole time.
And you have some time without side effects.
So what we're hearing through a lot of these questions is how varied getting a gist is, and the treatment path. So my gist was 8 centimetres in diameter, but 62 mitotic count. So I was told by gist specialists that for me it's not a matter of if it will come back, it's a matter of when it will come back, and that's likely to be 5-ish years. I'm 13 years down the road and my gist hasn't come back. So there is no definitive to any of this, and it's good that we can personalize the drug taking and look at each individuals and have that option to do that in a personal way. That to me is of great benefit of having specialists dealing with it.
In almost all of medicine, what we know through our interventions is we can change the chance, the odds, the probability of a future event. We can almost never categorically rule out or rule in a future event. All of our trials are based upon the chance of something happening. There's nobody in whom you do this and you completely protect nobody ever again will ever have such and such happen. Yeah, it's all about shifting the odds, the probability, and that's really hard because it's not how we live our lives. We don't live our lives in probability, but our medicine is in probability.
And there are always exceptions to the rule, good and bad. So, questions? Any more questions?
Thank you. Can you hear me?
Yep.
Good. I picked up on the fact that, and was repeated over there by a lady with respect to sunitinib, okay, and effectively this question of taking breaks and improving on the resistance factor. I didn't hear, I don't think, whether that also applied to imatinib in the first, for argument's sake, 3 years of treatment. That's one question. The second point, you pick up on things as a patient. Like somebody said to me, if you've got a problem with thyroxine, it seems to have the same side effects as taking imatinib. So I said to my oncologist, why don't you test for thyroxine? He said, yes, that's a good idea. He said, I'll do that when I take your bloods next time. And then also this question of plasma, the question of how much is, I don't know if it's the correct medical term, how much of the drug is actually being absorbed to actually increase the effect. And those 2 points relate to something which I think is all concerning to us, is in terms of educating, if one can say, the medical profession. When are we going to get to a point where oncology departments have, if you like, a standard list of checkpoints to apply as they're taking you through this journey in the initial stages of taking imatinib, for instance?
Okay, thank you. There's a few questions in that. I think to address maybe the first and the third, the one about intermittent dosing, drug levels, the notion of can we be smarter in the way that we game the kind of evolution of cancer and the selective pressures that our treatments apply. At present, this is largely in the realm of interesting theory, but theory, and one has to be cautious around that. At present, we are able to advise patients about the benefits on this based on the trial data that is already available to us. And the further that we move away from that trial data, the less our confidence can be that we're delivering it. Now, as I've already said, applying data from hundreds of people in trial to an individual requires, there's an art to that. But in terms of applying theories that haven't been completely tested to that person, one needs to be cautious because there's a real risk that in trying to be clever, you could actually put someone at a disadvantage. So I think a pragmatic approach, and particularly if there's bothersome side effects, which need to be addressed, individualizing doses on that front is perfectly appropriate and should be done. In terms of trying to apply theory about how the best these drugs can be doing ahead of reliable trial data is something to be cautious of, and I think this kind of applies to the plasma levels as well.
Thank you very much. And then I think the middle question was about standardization in some manner. In my mind, and your mind may be well ahead of mine, so forgive me, but in my mind, there's a tension between standardization and individualization. And if you have a really strongly written down that the right thing to do is A, and next time do B, and then at the next time do C, then you're going to get a lot of doctors who are going to just do that, and when asked to individualize something, they're going to say that's harder for me to do because there's this very standardized thing. Yeah, when doctors get into trouble and provide treatments that don't work or things that are problematic, their court is the other doctors. And if the other doctors say, I wouldn't have done that and I wouldn't have done that, and look, it's written down, I wouldn't have done that, then your doctor might be asked not to be a doctor anymore. Yeah, okay, and that's real, that happens all the while, you read it in the newspapers. Yeah, okay, so standardization and individualization are at tension with each other, and we need to reach the right point. That relationship, with your doctor reassured that it's not going to get into those conflict situations, lets the doctor give you either a very standard approach, if that's what your personality you'd like, or a very individualized approach, if that's what you want and need. So it's just if I've understood your question, forgive me if I haven't, and we can maybe chat, but if I have understood your question, then I think we just need to see that those are at tension potentially.
Yeah, thank you.
I've just got a question for Alex about the different generic preparations of the imatinib. So the question is, do you have any influence on what your pharmacy can actually procure? Because in the last 3 months, we've had 3 different types of imatinib, all with different side effects. And it's becoming a bit of an issue, really, a bit of a problem.
The short answer to that is a rather limited influence, which might surprise you, but as an individual oncologist, my ability to dictate terms in the broader, and this is at kind of NHS England level where these decisions have been made, it is limited. The price differential between Gleevec and some of these things, it's almost 100 to 1 level. It is a considerable thing. It's not marginal, which for people in your situation, I understand that may not be the main consideration, but at a macro level, these things do apply. My understanding of this, which is not very developed, is that there is bulk order purchasing power, and that's under kind of continuous negotiation. That it's more that what influences what's in your prescription bag on any given month. There is remit for this, and if there is a compelling reason to think that there are side effects more with one than the other, then certainly in my experience, we've been able to negotiate things where where possible, we're using one brand of imatinib preferentially. But again, it's an individualised discussion. But I would hope that if someone is clearly having a tougher time with side effects with one brand than the other, there would be some scope to negotiate a solution to that.
We certainly tweak the brand if at the individual patient level when we can access the medication. I'm not hiding at all behind this, but it's just a truth that all the disruption that there's been in the world in the last few years made it harder for people to have treatment breaks, and it made it harder for people to have the individual brand of a medication, not just this medication, but a whole host of medications. And that was to do with the treatment breaks thing was about lots of people wanting to stop cancer treatment if they thought they were at risk of catching the nasty viral infection. Yeah, I mean, hundreds of thousands of people wanted to stop treatment temporarily. There was no evidence, and somebody had to make a ruling as to what was going to happen, and it was to discourage treatment breaks for that reason. And so we've got to fight back against that, push back against that, now that these viruses are much less of an issue. Yeah, still something, but much less. And then in relation to the brands, that's about supply lines. Yeah, okay, so it's lovely to think that I might have all 5 or 6 brands of imatinib in the pharmacy, but any 1 week, they may not all have made it on the lorry. And that's really what it's about.
Yeah, plus there's this, the situation with regard to monitoring whilst COVID was going on. You didn't mention the word, I tempt fate, but the monitoring regimes were restricted, presumably during COVID as well. That made it very difficult to get patients in to keep an eye on them. So if you're going to have a change in your regime, you need to be monitored with that. So that made it difficult.
All of these catastrophes, whatever catastrophe it is,
yeah,
they have ongoing consequences that we will have to fight against for decades.
Yeah, sure. Yeah, it's a lasting effect.